Hello, my name is Shernan Holton. I'm Associate Professor of Medicine at the University of Minnesota. My research focuses on making allogeneic transplantation safer and reducing graft versus host disease, both its incidence and severity, and providing new treatment options. Today we wanted to talk about some of the new breakthroughs in chronic graft versus host disease. As you know, this has been a difficult area for our field for decades. We've relied on immunosuppressants borrowed from other fields such as rheumatology to help treat chronic graft versus host disease. The paradigm has largely been immunosuppression, giving some kind of medication to reduce immune activation and hopefully reduce chronic graft versus host disease symptoms, but that rarely helped to reverse the tissue damage that was already done from chronic graft versus host disease. There have been a lot of recent FDA approvals that we wanted to highlight, as well as ongoing clinical trials that are exciting us and we hope will provide additional options in the future. Briefly, let's just start with the risk of chronic graft versus host disease and the burden that we currently see. Currently, about 30 to 50% of patients undergoing an allogeneic transplant will experience chronic graft versus host disease. If it happens, it usually happens within the first year post-transplant, but sometimes it does come on later. The mainstay of treatment for chronic graft versus host disease is still corticosteroids, so prednisone. Prednisone is the most common drug that we give, and usually we give it in combination with a second agent to reduce the burden of the steroids. Most commonly at the University of Minnesota, we're giving prednisone along with sirolimus, but other medications that are immunosuppressants used for GVHD prophylaxis can also be used, such as cyclosporin or tacrolimus. So usually a 2-drug regimen of prednisone plus one other immunosuppressant is the first-line therapy for chronic graft versus host disease. This helps to improve symptoms for most, but can rarely completely resolve it. And a lot of people have a difficult time getting off of prednisone. As they taper it, the symptoms can sometimes flare, and we're back on high-dose immunosuppressants. To try to address this unmet need, multiple studies have been undertaken over the years, starting with laboratory studies that have eventually translated now into FDA-approved therapies. I wanted to briefly mention new FDA-approved drugs for the treatment of chronic graft versus host disease. But note that all of these treatments are now in the second-line setting or later. So basically someone has to have prednisone or some related treatment similar before they're even eligible to get some of these newer treatments. The first drug that was FDA approved for chronic graft versus host disease was ibrutinib. This is an oral medication that was originally developed actually to treat B-cell malignancies. So it reduces B-cell signaling as well as some T-cell signaling as well. So this is an immunosuppressant or an immune modulator, but has activity in chronic graft versus host disease, and was actually the first ever FDA-approved drug specific for graft versus host disease. In more recent years, we've had 2 more FDA approvals. We've had belumosudil, which also goes by Rezurock. This is a ROCK2 inhibitor, also an anti-inflammatory immune modulator that has a unique feature that it can also help target some of the fibrosis pathways, or the pathways that cause scarring in chronic graft versus host disease. This is also an oral medication, again FDA approved, but only after prior lines of therapy. The most recent FDA approval for chronic graft versus host disease is a medication called ruxolitinib, or Jakafi is the trade name for this medication. Believe it or not, this was actually the first FDA-approved agent for the treatment of acute graft versus host disease, but we knew it had activity in chronic as well, and this was confirmed in multiple clinical trials, including a phase 3 study comparing it to best available therapy, where clearly it had a better response rate. So now ruxolitinib is also FDA-approved for chronic graft versus host disease. So now in our armamentarium, we have 3 FDA-approved agents to work with, and usually we're timing or sequencing these based upon multiple patient factors and the potential side effect profile and what has worked for the patient in the past. So all of these are good options for us, and we use all of them in our clinic regularly today. In clinical trials, we have additional agents that are being developed that can more help target the scarring or fibrosis that I had mentioned. Immunosuppression can sometimes help reduce ongoing scarring or tissue damage, but it doesn't help address that is already there. A recently developed molecule called axatilimab is an intravenous medication targeting a different cell subset that has a role in chronic graft versus host disease. This targets macrophages. These cells help contribute to scar tissue, and the hypothesis is that depleting these cells that can help drive scar tissue can help reverse and improve some of the fibrosis in chronic graft versus host disease. A phase 1 study has been completed. A phase 2 has just recently completed enrollment, and we're awaiting results. This is an intravenous medication, unlike the others, which are oral agents, but appears to have a lot of promise in improving the mobility of skin and joints. So we're really excited to see what the phase 2 results of this treatment show. So more options than ever are available, and we're continuing the work to try to improve organ function and skin resilience and joint mobility, address chronic pain, address diet, and address muscle mass. Multiple areas of chronic graft versus host disease that need to be addressed further. So we're still working on all of these areas. In the background, we're also working on better prevention for chronic graft versus host disease in the first place. The ideal situation is that in the future, we significantly reduce or ideally eliminate the risk of chronic GVHD. And so look for some studies that will be presented at ASH this year, the American Society of Hematology meetings, about some new approaches to GVHD prevention that might not just prevent acute but also chronic graft versus host disease as well. I hope this gives some hope for those who are considering transplant and worried about the potential for long-term side effects. So our field has made tremendous strides in the past decade, and I think this will only be accelerated in the future. The most important thing you can do is be open and honest with your physician and care team about your symptoms, participate in research when you can, and even give us research ideas, help contribute to the studies that will help make a difference for patients in the future. We can work on this together and continue to see some significant improvements. Thank you for this time. Great talking to you.